Actually, I did not leave engineering for medicine because I wanted to, but at that time we had severe ragging, and I was beaten up and thrown out of the first floor of the engineering college where I was studying, and that was how I was an accidental doctor. This is the Barak River in southern part of Assam. I don't know whether many of you know about it, but the Brahmaputra River valley in the north is much more popular. This passes close to our home. So my wife and me, we moved from Tamil Nadu to Assam about 28 years ago. And that is the location of the hospital, very close to Bangladesh, very close to Tripura and Mizoram borders, the southern part of Assam. So this hospital actually was started as a leprosy colony because in those days, leprosy was not curable and they were just looking for a large piece of land. So 1,000 acres of land was purchased and that became a leprosy colony with about 400 leprosy patients. And the hospital was closed in the 1980s when all the foreign missionaries were asked to leave India. They were not allowed to come back. And when we went and joined that hospital, it had been closed for 10 years. And we were very far away from other hospitals. The large similar hospital was 100 to 200 kilometers away in different directions and 4 to 6 hours by road. So this was the hospital when we went there in 1992. It was completely closed down and in a very dilapidated condition. But it was a very thickly populated area. And because of isolation, poor roads, broken bridges, and various reasons, we had some of the worst maternal and infant mortality rates in the country. Our maternal mortality rate was more than 500 at that time. And people were very poor. To travel long distances and get treatment was beyond their means, and they quickly became destitute if they had to travel for secondary or tertiary medical care. And as you know, this is a part of the hospital which was under floods a few years ago. So Assam is prone to seasonal flooding, and that causes road blockages. I think here there were more than 1,200 trucks on the road blocking it completely. And people died in their own vehicles of bleeding and obstructed labor and so on. And road access was also not good. People had to be brought down to the main road using various means. So you may wonder why we went there. So I just wanted to quote one verse from the Bible. So if I were to assume that God was controlling me, that means controlling my body, my mind, and my spirit, then He has a plan for me and He wants me to do something with that. So if I understand that those are the best plans I have, then I will call on Him and ask Him, what exactly do you want me to do? And then He will tell me. And that is a turning point in my life, because till then I really wanted to be a cardiologist, go abroad, and because I was really fascinated by cardiology and the cardiologists in my hospital at that time. So this was what I got. Go to a place where you and whatever you have, your knowledge and skills, will be of the greatest transformational impact. And transformational impact was defined as population of a place divided by the resources available. And resources are other people like me. So for instance, if I was in Chennai and there were 60 pediatric surgeons in Chennai, it will be the pediatric population of Chennai divided by 60, and probably less than that because I would be a new entrant in the field. But here in Northeast India, I was the only pediatric surgeon for Mizoram, Tripura, Manipur, Meghalaya, and southern half of Assam. So it's almost like the population divided by 0. So that produces maximum impact. So that is the first learning, that for great impact, we need to travel to places where the resources are very low. So when we went to this hospital, the board members of this place, they wanted us to stay on till retirement because they didn't want to make any commitment taking on a new couple of doctors when they were not sure whether they will stay long term. So they requested us to stay till retirement. So we made a 30-year strategic plan. We are now in our 29th year in this hospital and nearing retirement. So for the first 10 years, we wanted to become a stable hospital because there was no income, no patients. We wanted to study the local communities and make poor-centric strategies. The second 10 years, we wanted to start some major initiatives which would be completed by the time we leave, so that they will not be a burden to the next set of leaders. And in the last 10 years, to understand the knowledge that we have gained and to share it with other similar situations in the developing world. So the number of items on the left are what is traditionally called as business planning. So this is what hospitals and institutions plan to achieve. And the ones on the right are what we call as transformational impact strategic planning. So for that, we need to define who is our target population. So we said that the poor, how can we reach them? What are their characteristics? How can we close the gap? Meaning get them to come to get services and to create permanent changes along with partnerships and empowering them. All this within a realistic time frame. So these are some of the steps of what we did after doing a SWOT analysis. That is our mission statement. The first one says to provide affordable healthcare, high quality healthcare. The second, to start other projects because we have a broad mission memorandum of association. And the third is on training. And these are core values which should be converted into practices and protocols. So initially we needed to create stability. This hospital had no water, electricity, no money, no patients except for the 60 leprosy patients. The old staff were not willing to work. There was no external source of financial support. Till about 2 years ago, only about 1 to 2% of our income came from outside the hospital. And nearest phone was 50 kilometers away. So each of these issues was analyzed and we made ways to get out of them. So individual staff should understand that they are valued members and the senior staff should act as role models and mentors. We cannot give large salaries, so we must create other ways for people to be fulfilled. And when people go out, they should be seen as our ambassadors. And staff should say that I am working for God, for His approval in my life. Difficulties I face are only temporary and trivial inconveniences. I have made a vow to live and die. Die meaning not physical death, but to our own ambitions and desires. I love the people I have been called to serve, and I am privileged to be part of a great team. So currently, the hospital has all these things. We are entry-level NABH accredited and also have the TIS certification. So last year, this is our statistics for a 200-bed hospital. And you will notice that the delivery numbers are quite high. Not last year, the year before. Last year was affected by COVID. This is our present labor room in ICU. So in the second phase of our strategic plan, I told you we started 3 big initiatives. The first one was on education. So we realized that tribal children who tribal languages all here use the English script here. They all dropped out of school in class 4 and 5 because they had to learn in Bengali. So we started an English medium school affiliated to local Assam board. And at present, 1,200 children study in the school, 200 in hostels. So 3 of them last year got into MBBS. People are in IIT, Guwahati, and so many other colleges. And many of them have even come back and rejoined our hospital staff and started contributing to their communities. So this is the first big investment. The second investment, we realized that for our hospital's model to succeed, we need large population. But there are many places like Arunachal Pradesh where the population density is very low. And for that, we decided that the only way out is to have nurse-run healthcare. So in 2006, we started an A&M school. 250 of nurses have now passed out from all parts of Northeast India and serving in remote rural communities. This year, this is being upgraded to a college of nursing. with funds provided by a Dutch philanthropist. The third big problem in Northeast is militancy. So Tripura at that time was very badly affected by militancy. We started a small dispensary in one of the most militant infested parts of Tripura. And today it sees about 10,000 patients. We have a family medicine specialist, and we hope to upgrade this to a larger hospital. So that is all vehicles traveling with armed escort with a person with a machine gun. This was in the early 2000s. And we also wanted to help people in other low resource settings across the world. And we have this partnership with the Royal Dutch Tropical Institute in Amsterdam. And every 6 months, 4 of the residents come and stay with us for six months. And they get the MD in global health and tropical medicine. And then they go on to serve in very remote places across the world. South Sudan, Ethiopia, Papua New Guinea, and so on. And these are 4 of those residents. And I have contributed a chapter in their Dutch book on global health. So these are various partnerships we presently have, research partnerships and like donor partnerships. So we must understand the world of the poor before we can make any innovations for them. So this is an article which I published about a lady with a 35-kilogram ovarian tumor. So this lady had, the family had decided not to operate on her because the expenses would be too much. They would have to sell everything, and the outcome is not certain that she might be cured. So they felt it is better that she dies so that the husband can marry another lady. So this sort of problem would not be seen in a developed part of the world, like probably the southern states of India. People come too late. They keep on postponing. And this lady has come with 4 eggs for her treatment. She doesn't have cash. And there is my wife. So last year, an article was published along with the researchers from the Wharton School of Business on the Makunda model. So it describes all the innovations that we have made and studies their impact over the past 25 years. So the poor finance their healthcare by distress sale of vital assets. Distress sale meaning selling something at a cost that is much lower than what it actually the actual value. So they might sell something valued at 75,000 for 15,000 because they need the money by Thursday, or borrowing at 20% or 10% interest per month, or begging. And this is a behavior of poor people when they come to hospital. They keep asking about the bill because they know exactly how much money they have, and they're afraid that once it goes beyond that, they will have to sell a vital asset. They starve in hospital. They share one meal among the whole family because they can't afford to spend on food. They come late for treatment and want to go back quickly. They want to go take a sick person home before he dies because it's very expensive to transport a dead body. And they want to wait for, they were not willing for referral. They think this is the last stop. The not so poor people, they demand attention because they think they can go to another place. They haggle over bills and estimates. The poor people don't haggle because they don't want to spoil the relationship with you. They ask for special rooms and special facilities. And even though they can pay the final bill, they still want to ask for charity. So poor focused treatment protocols should not have too many investigations. They should not use too many drugs. They should adopt time-saving tactics like doing all the investigations as outpatient so that the inpatient time is reduced. They should use good quality monitoring so that bad decisions are not made. And final, the down payment should be discussed at admission. So a procedure, the total cost comes to 15,000, and we find out that this person can bring only 3,000 rupees without selling a vital asset. So we say pay 3,000, rest free. So that should be done before, and we should not ask for anything more. I think I have explained all this. All the staff should know what are the signs and symptoms of poverty. So some people have dignity. They don't want to accept charity. They want to keep it as due. But then when the due amount is kept for a very long period, they are afraid to come because they know that they have to pay a due. So on the 31st of March each year, we write off all previous dues and we start off on a clean slate. So these are what we, I think, reorientation for management of poor people. We all have a gold standard protocol, which is taught in our medical colleges, but often it is too expensive and uses components like MRI scan and so on, which are not available in remote areas. So realistic healthcare provision should be affordable. Otherwise, people will default. If you charge somebody 500 rupees each time they come for management of diabetes and hypertension, when they can only pay for 150 rupees, they are not going to take it lifelong. But if you can give them an older drug, which is now cheaper, it may not be the best one, but it's much more realistic, then it's more likely that they will comply. And we have made various such innovations. For example, choledocodiagnostomy for common bile duct stones instead of PRCP and so on. So most hospitals, they develop a costing procedure to say this is how much the procedure costs. So we instead did a pricing procedure. This is how much the person can afford. So for example, we have said that the ICU, NICU charges, including ventilation and all procedures, excluding drugs, is fixed at rupees 500 per day. So obviously this is a highly subsidized cost. So how is it possible to do that? Because we do more than 25,000 ultrasounds in the hospital, and the ultrasound department can subsidize the intensive care department, internally cross-subsidize. And sometimes we find out that a person has already sold a vital asset, and we send our hospital staff to retrieve that vital asset and give it back to the patient. So this is done because very often the person who has purchased it at a very good price is unlikely to return it, but they will return it to the hospital. So these sort of small gestures make people to say that this hospital is for people like us. And sometimes an unexpected complication occurs. So bile leak may occur after a biliary surgery. So this might make the patient who was expected to go home in 2 days to stay for a month. So whenever an unexpected complication occurs, we write off the entire bill and provide free stay for the patient and relatives. So again, this is something that may happen 2 or 3 times a year and easily within the capacity of the hospital to support. But for that patient, it makes a big difference. So poor-centric strategies bring very large volumes. Our bed occupancy is close to 100%. It should make institutions self-sufficient. And it produces transformational impact. So we define transformational impact as when an excluded populations become included. So incremental impact occurs when existing service becomes cheaper, more convenient, and better quality to people who are already getting that service. But transformational impact occurs when people who are not accessing that service are now able to access because it has come within their capacity to access. So we need to brand our services. So the best way to brand is to provide good quality treatment so that people tell others that this is a place where they should go. So we do not have private rooms in our hospital and no private consultation, simply because it creates 2 classes of patients. So we want the poor people to say that this hospital is for us. So if a rich man comes, he will have to stay in the general ward. He cannot be seen earlier than a poorer patient. And that removes that class feeling. And the focus should therefore be on our target population. So I think this is all mentioned already. And this is how the competition is. So there is a very large blue population, and there are middle class people, the violet group, and a few very rich people. The rich people all go to like Calcutta or to Vellore for their treatment. The middle class all go to nursing homes. So the big competition for a hospital is to compete with other nursing homes. The poor people go to government facilities or do not go to medical, allopathic medical care at all. So if we are competing in that group, we will be filled with patients, and that is what happened to us. So competition actually moves further away. So I just wanted to tell you about this maternal and neonatal mortality. So in our hospital, I told you the MMR was very high. But from 93 till 2007, our delivery numbers did not increase. So in 2007, we were still having only about 500 deliveries a year. So we did a lot of community observations to understand what was happening in the villages. So we realized that people were delivered by traditional birth attendants, each community having their own senior attendants, some of them male attendants. And these people, they went to the home of the mother and stayed there for a week. They did the work of the mother, cutting firewood and cooking and looking after the children. And it was an extremely convenient arrangement. And in return for the care provided, they were given a bag of rice, a sari, or a few hundred rupees in cash. So compared to this, going to the institution for delivery meant a complete disruption of the family life. And they were afraid of massive cost. So it is very easy to understand why they did not go. Obviously, many people died in the village because if somebody had eclampsia or postpartum hemorrhage, nothing could be done in a remote village. So when we told them, has anybody died? They said, yes, my grandmother died or my aunt died, but that is her fate. Means it is acceptable that some people are going to die. So we realized that it is impossible to change this situation. And the most important people for changing this health-seeking behavior was these traditional birth attendants. So until then, we were looking at them as quacks. But then we realized that they are very important. So we invited them and started talking to them about their experiences. And slowly they told us a lot of like horror stories. So we get really terrified when somebody dies of bleeding in our hospital, in spite of giving blood and on whatever we could do. Sometimes people die. So it would have been much more horrifying when something like that happens in the village setting. So we told these people, when such things happen, when you have a high risk patient, why do you want to take that risk? Bring that patient to us. So these traditional birth attendants started to bring high risk patients, eclampsia, obstructed labor, bleeding to the hospital. And we praised them in the presence of the community. So soon the patient started to realize it wasn't that bad. And why not go for a normal delivery also? So within 1 year, the number of deliveries increased from 300 to 1,300. In 2 years, 2,300, then 3,300. In a few years, it had increased to 5,000. And today we have 6,800 deliveries. So this is a lesson that health-seeking behavior should be understood by understanding the compulsions, social and economic reasons why people make their decisions, and then making the correct intervention so that everybody is win-win for all. These traditional birth attendants later on became ASHA workers when that program was started. And we got enrolled with a public-private partnership with the government of Assam. I think now we have paid over 2 crore rupees to mothers from the state of Assam. And obviously neonatal outcomes also become better because if a baby does not breathe, we immediately have all the facilities to resuscitate that baby. And this is the impact. MMR reduced from 474 to 281 in 4 years. So obviously our hospital is not the only reason. This is for the district. But we were serving a large isolated population because of the bad roads. And that was where the maximum deaths were happening. So I think we contributed very significantly to the reduction. So our district hospital was seeing much smaller numbers. And only the medical college, which was about 120 kilometers away, was seeing a larger number of deliveries at that point in time. So earlier years were very difficult. I told already that we had no electricity. So our first operation was a cesarean section done at night without electricity using local anesthesia. And oxygen had to be brought from 400 kilometers away, sometimes by boat because the roads have been flooded, and we had to ration the use of oxygen. So what do you do when there is no electricity and when there is no oxygen? So we use a machine like this, Epstein Macintosh Oxford vaporizer, ether vaporizer, using just atmospheric air and ether. So although my wife had done her MD in general in anesthesia, she gave anesthesia with this machine for more than 10 years, till we were able to provide electricity and were able to operate a Boyle's machine. Today we have 4 operating rooms with 4 anesthesia workstations and 2 large oxygen plants. So that is my wife with my elder daughter on her back, and that baby has been just operated. This baby had a tracheoesophageal fistula, and after the surgery, baby cannot breathe, and we did not have oxygen. We did not have. It means we had oxygen, a little bit in cylinders, but we didn't have a ventilator. So my wife was the ventilator. So she ventilated the baby for 4 or 5 days till the baby could breathe on its own. So you may wonder what happened to all these babies. This is the baby in the previous slide. She's just finishing class 12. And you may be surprised to know that all these babies survived, because this is the best model of ventilator. You have a ventilator with the monitor attached. So this, as soon as the tube is blocked, you can immediately change the tube and so on. So these babies all had personal attention and they became well quickly. So this was our first pediatric surgery patient brought from Meghalaya, referred as intestinal obstruction, but actually having posterior urethral valves with urinary ascites. So we did not have the neonatal cystourethroskop to operate on this baby. So we just did a bilateral high loop ureterostomy, and that is the picture on the right. And the central picture is taken about 7 years later. Now this boy must be 20 years old. And we got a gift of the scope some years later, and we were able to fulgurate and close the ureterostomy. This is a teratoma of the middle lobe. So we did a middle lobectomy again 20 years ago in a 16-year-old lady who later on went to have many children and is now doing well. She came with massive hemoptysis. So in spite of remoteness, all sorts of complicated surgeries are possible. So now there is a lot of talk about climate change. So in those days, we had thousands of malaria, cerebral malaria, hundreds of deaths. And today we have no malaria. So there is a positive development because of climate change. Probably the vector is badly affected by the changing or warming climate. But in other ways, the forests are disappearing. And these are the last intact low altitude dipterocarp forests in India. So about 10 years ago, I started, after I had a heart attack, I started documenting biodiversity, and we have done a lot of research on biodiversity. So that is me, along with another member of our club. We have the highest number of observations from India in various citizen science portals and published a lot of articles. We have documented about 250 species of birds, 350 species of butterflies. So this is another thing that I feel we must all look at beyond being doctors wherever we are posted, because there are many other things to discover in those places. There may be cultural things that can be absorbed. There could be photography and so many other things which might have a social impact. This was the first of our publications. We have now 10 publications in biodiversity, and some more are on the way. And since we are all academicians, I thought I should talk a little bit about some of the research work that is being done at our hospital. There were two projects which I did when I studied at the Christian Medical College in Vellore. I did my MBBS in the Kilpak Medical College in Chennai, MS at Madurai Medical College in Madurai. And then between 97 and 99, I did my MCH in pediatric surgery at CMC Vellore. So research, I would say, has good, bad, and the ugly. So if you look at the ugly part of research, it is entirely based on recognition and maybe publications, and often doesn't translate into good outcomes, especially for the poor and marginalized. So this is one research which I was very impressed. So in those days, gastroschisis was not treated unless we felt it could be operated immediately. If we felt it could not be operated, we said, I'm sorry, we can't do anything. But one day, one of our doctors, Dr. Nainan Zakaria, in that written there, my consultant, I was also assisting him in that surgery. He operated on a gastroschisis. And when the bowel was put back inside, the baby was unable to breathe. It means the anesthetist said, I can't ventilate. So now what to do? We can't, we already committed to the surgery. So we knew from research done in the USA that expensive external silo could be created, but we didn't know what to do because we didn't have that sort of equipment with us. Very expensive, it cost a few $100,000 or so. So we made a silo using a plastic bag from a urine drainage bag, and that baby survived. So after that, we did a few more, I think 3 more patients after that, and all 4 survived. And then we published it. This became the gold standard for gastroschisis across the developing world for many years, until last year when a newer technique has been discovered. So that is one of the babies operated here in Makunda with a silo. This is other very interesting research which I did at CMC Vellore. Again, our senior professor, Dr. Sudipta Sen, he was the one who did the first surgery. So when we have bilateral hydrated cysts of the lung, it is very difficult to operate. So as soon as you operate, air leaks into the pleural cavity and the lung collapses. And soon they develop bronchopleural fistula. And then if that happens on both sides, obviously the patient is going to die. And then these people have a very stormy post-operative period. So we were just going through the literature and realized that there was a very, very old operation called pneumonostomy done for lung abscesses in the pre-antibiotic era. So we thought, why not try that out on hydrated cysts? So this was done on 6 patients. So instead of removing the cyst and then putting in a pleural drain, we removed the cyst and put in an extra pleural drain. So that catheter is actually coming out of the body, not communicating with the pleural cavity. It's like a gastrostomy. So after what is happening is actually the cyst is producing multiple holes in a lot of bronchi because of pressure. And when you remove the cyst, all of these bronchi leak into the cyst cavity. And when the total surface area of all the holes is greater than that of the glottis, then the lung will collapse. So here what happens, all the air is now going outside the body. So after a few days, you can pull out that catheter and it becomes a broncho-atmospheric fistula, which is like a tracheostomy. So air is whistling in and out. But the great thing is the lung does not collapse. So these patients have a completely normal recovery. They become quickly all right and they go home and there is no loss of lung tissue. So this is now the gold standard for the treatment of this condition and used all across the world. This is our first publication from Makunda. So we realized a lot of people are having beriberi. So the case fatality rate for cardiac beriberi is 100%. So we realized a lot of babies are dying and they all recovered when you gave them Thiamine. And this was recently published in Indian Pediatrics. They all present with shock along with the high anion gap, that means lactic acidosis. This was also published in the Annals of the New York Academy of Sciences. along with the other manifestations in adults, neuropathy and cardiomyopathy. We also saw a very large number of rare cases. So this is advanced primary abdominal pregnancy, all of them in the 3rd trimester. One of the mothers actually delivered a live baby, which is around 2.8 kilograms. So all of them are intra-abdominal peritoneal pregnancies. This was published recently based on our experience over the past 10 years. And a few months ago, we published this. So this was a boy who came with extensive bowel gangrene. So much of bowel gangrene incompatible with life. So what to do? If you resect all that, then we cannot do TPN and put him on try for small bowel intestinal transplant. So we just used a Bogota bag, which is similar to the silo I mentioned earlier, and waited for 18 hours. So after 18 hours, we found out that this patient actually had recovered. I mean, it's not fully, but now 100 centimeter of bowel had recovered vascularity, and this was published. It probably can be used in other causes of acute mesenteric ischemia. And this is a study we did along with the people in University of Oxford, gastrointestinal neonatal anomalies. So the rich-poor divide, what happens in various countries? A very interesting publication published in Lancet a few months ago. And this is our Thiamine problem, again published in Indian Journal. And this is a recent publication. Impact, again, using a large collaboration, multi-centric collaboration with many hospitals in India. We have studied the impact of COVID on more than 200,000 hospital births. And people are not going to hospital for their deliveries or for other obstetric care. And that results in adverse outcomes. Partly because of travel restrictions, lockdowns and so on, and partly because of fear that if you go to hospital, you will get COVID. So probably one way out is to say that this hospital will not treat COVID. It will be purely for the non-COVID patients. And there will be special hospitals which will treat COVID so that non-COVID emergencies, medical, obstetric, surgical will know that they will be safe in this particular place. This is also published in a sister publication of the Lancet. And we were part of a big study done by the Indian School of Business, sponsored by this company Ernst & Young, on identifying enablers and barriers to equitable healthcare. So it was very interesting to also learn from the experiences of other similar hospitals. And last year, we were one of the hospitals selected by NITI Aayog for a study conducted by PricewaterhouseCoopers on the not-for-profit hospital model in India. So this was also again published a few months ago. And a lot of very interesting findings have come out, which have been recommended to the Government of India, Ministry of Health and Family Welfare, to consider when they make plans for the future. And there are many hospitals like ours, not only in India, but across the world. And many of them are totally invisible. Nobody knows about them. They are, nobody gets, these hospitals do not get funding. They do not get volunteers. So how do we make these hospitals visible? So last year we did another project with the Wharton School of Business to develop an impact assessment, impact rating system, which measures the impact, the potential for transformational impact. And by looking at it, potential donors and potential volunteers can say, this place will be the place I should go to, because that is where the greatest transformational impact is likely to happen. So we have submitted this to NITI Aayog, to Securities and Exchange Board of India, and various other bodies in India and abroad. Currently, research is also going on heart failure in pregnancy. So I have retained my interest in cardiology. I do all the echocardiographies here. So we do echocardiograms in pregnancy using a handheld machine, and study is going on with many centers in India. And similarly, maternal and neonatal health, big study in our block with CMC Vellore and the Gates Foundation. We are also developing some devices and software with the IIT Madras and IIT Guwahati. And we also discovered that we have encephalitic form of Beriberi. So we are doing a study on that because this can be detected using neurosonography, transcranial ultrasound. We are involved with a partnership with the government of India, government of Assam. So I already told you about the Janani Suraksha Yojana scheme. But in this private-public partnership, the government does the community part of maternal and neonatal care, and we do the institutional part of the care. And we are paid about 15 lakh rupees a year by the government. In exchange, we give a charity of 3.5 crore rupees to poor people. We are also involved in the training of skilled birth attendants, that means nurses in government hospitals. And this year we received a very big grant, 5 crore grant, one of the largest grants we have received so far from the government of India. With this, we are able to buy a CT scan and some other machines because the nearest CT scan is 40 kilometers away. It's nice to have an in-house CT scan, so we don't need to refer patients with the stroke and other conditions where a time-sensitive decision needs to be made at an affordable cost. So I went to a global surgical hackathon in Uganda, arranged by Camtech, which is a consortium of Harvard Business School, Massachusetts Institute of Technology, and Massachusetts General Hospital. And when I presented our model and told that we are high quality, they said, you cannot be talking about yourself. Get somebody else to assess you and say that you are high quality. And that is why we did this NABH entry-level accreditation given to us in 2018, again renewed in 2020. And this model itself, they said you cannot talk about yourself because you will leave out the bad parts. And that is why we invited researchers from Wharton to do the impact assessment study. So in 2016, me and my wife were given this award for lifetime achievement by CMC Vellore, given to one of its alumni for good quality work. But in the Bible, we have this verse, well done, good and faithful servant. Meaning that we should not be looking for rewards in this world because there is a life to come. And our reward is really in heaven when we go there and are welcomed back. You have been obedient, you have been trusting, and you have done what we asked you to do. And that is what we should be living for. So we had difficulties. So when we came to this place, we did not know any language except Tamil and English. So the local language here is Bengali. We did not know that. The culture was different. The food was different. And there were minor inconveniences that we needed to bear. Electricity and water, I already mentioned, was not available. So it took us 14 years before we could provide electricity and water to our staff quarters. So all those years we lived with kerosene lanterns, and water was carried from nearby water bodies. The nearest phone was 50 kilometers away. We had to travel all the distance, and very often when we reached there, they would say, today it's not working. When telegrams were sent, we received them many days after whatever event was described in the telegram. But talking on the phone was also not very encouraging. So because when we spoke to friends and relatives, they thought we were quite mad. And I had a heart attack in 2008. At that time, streptokinase was out of stock in the hospital. I could not be given the medicine on time. And later on, I went to Vellore and had a stenting done, but my ejection fraction is 35%. So That was a bit of a problem. I also developed leprosy from the leprosy patients here. Not because I was doing a lot of leprosy work, but because I had low T cell function. And when I was started on multi-drug therapy, I developed a lot of reactions. So I was put on steroids and developed hypokalemia, hypocalcemia. I developed tremor. So I was on all these medicines for more than 2 years before I could be slowly weaned off. Other big problem was when we are completing our medical training, we are fairly confident about managing our medical problems, but we don't know anything about finance, law, management, planning. So all this I had to learn by myself at a time when internet was not there and not able to contact people. So maybe this is something that should be considered for people going to places like ours. So some years ago, we started a short training program for medical mission doctors so that they may not be completely unprepared like we were. And similarly, we had no support in the early years. We had to really struggle. We had people filed false criminal cases against us because of encroachment of land and so on. So we had to go through a lot of difficulties, but God enabled us to overcome all of these inconveniences. So I'm not saying that everything is rosy and all going to be great, but we should look at all of this with the correct perspective. I always say that we should not underestimate what God can do in the long term, and be prepared to put up with difficulties for some years so that we can see all these great things happen. So every year, a large amount of money is spent on healthcare, billions and trillions of dollars. But this amount goes to the same set of people, included population. And every year they get the treatment more effective, more comfortable, more convenient. But excluded communities exist, even in our own country, because of remoteness, because of poverty, because of insurgency. So these people die of appendicitis, they die of tuberculosis, easily treatable conditions. And they die in their youth. And this should not happen. So unless these communities are included, equitable transformation will not take place. And some of the learnings from our model can be used to close these sort of gaps and which can produce transformational impact. So institutions should not just exist to make a profit or exist to keep their staff happy. They should instead focus on transforming local populations. So for example, if our hospital had wanted to become very wealthy quickly, then we would have had a lot of private rooms. So what would have happened? All the rich patients would have come to our hospital. Instead of going to a hospital 150 kilometers away, life has now become so much more convenient to them. But what happened to the poor people? Earlier, they were not going to that hospital 100 kilometers away. And now, even though there is a hospital just next door, they are not still going to the hospital because it's too costly for them. So we have to make these deliberate decisions to identify target populations, excluded populations, and make our plans so that they become accessible. And staff should be oriented to this mission and vision. So we had a 3-day orientation. In those days, when people joined us, they found that there was no electricity. They said, this is not too much. We can't work in a place like this. So we said then, okay, we're sad to say that we can't provide that right now. It might take some more years. But if you are not happy, then you will have to leave. And it is possible to run a hospital focused on the poor with affordable, high quality healthcare on a sustainable basis. So 2 years ago, we had a turnover of about 20 crore rupees. We gave 3.5 crore as charity, and we still had 1.5 crore for development, in spite of not having private rooms, private consultations, or large donations. The last 2 years, we have got a lot of donations from various donors. But we have showed that even without that, it is possible. So to conclude, projects should be started in areas where poor healthcare indices will provide the greatest transformational impact. So it's called the low-hanging fruit. So when maternal mortality is 474, just starting the hospital will bring it down to 250. But when it is already, I am told that it is 44 in Kerala. So when it is 44, bringing it down to 40 will be very difficult, almost impossible. So the greatest transformation for the lowest investment occurs in the places with the worst healthcare indices, and that is where we must go. So our model works in our situation very well because of a large population. So it might have to be modified in another place where cultural practices are different, manpower availability is different. But principles from our model can be used almost everywhere. So this is the question: are we willing to take the road less traveled? So for most of us as doctors and specialists and super specialists, the road before us is already set by the people who have gone before us. And where are they going? They are going to the Western countries. When they go abroad, they are not going to the Democratic Republic of Congo or the Papua New Guinea or places like that, which are worse than India. They go to the more affluent countries. And within our own country, where do they go? They go to corporate hospitals or places where they get good recognition. But if we would rather go to places like these, would our training and skills and knowledge not be put to the much greater impact? And that is the question I would like to leave with all of you. That is my family. My two children studied in our school. The elder one did her class 12 in our school and then did Bachelor of Social Work in Bhopal, and now is joined for her MSW in Trichy. Younger daughter is doing class 12 in Bhopal after doing class 10 in our school. We are very close to retirement and probably will retire in a few months from now. And these are our staff today. So we must acknowledge the hard work put in by numerous people from all over India and maybe some other countries also who came and joined us, especially in the earlier years when things were really difficult. Many of them had no obligation to work with us, but they still came and joined us. And finally, to God, who is the source of all wisdom and strength and encouragement to us, we owe all our thanks. Thank you very much.